I'd like to thank Annette because on Tuesday when we did this, they only read 3 letters and they all mentioned Dr. Bachnick. So thank you for actually mentioning my name. So I'm going to be very apologetic that I am not Dr. Bachnick. So I want to start off and just tell you a little bit about myself. I've been a practicing physician for about 15 years now. I started off in family practice, and really the last 6 years have been really dedicated to the care of the hospitalized patient. I spent 3 years at William Osler, at Etobicoke General and Brampton Civic before moving up to the country for a better life and coming to Alliston. When I started here, I started in family practice and working at the hospital, but I found quite quickly that I felt that my services could best fit this community by just working at the hospital. So after a brief year back in family practice, I left and went back to the hospital, and I've been there ever since, and I've been happy and thrilled to be there. So my days are just at Stevenson Memorial Hospital. Just a little bit, and Annette touched on this, and Joy touched on this, about what a hospice is and what is this. It's a relatively new arena of medicine. Probably the last 10-15 years we're seeing hospitalist programs pop up all over the province, all over the country, in the United States. Small hospitals, big hospitals, teaching centers, just really to help care for the person that's admitted, because there's a recognition that people that are sitting in or lying in a hospital bed actually need more time than the ones that are walking into your office. So it's been through that dedication that at Stevenson they've gone ahead and forged through with this model to really try and dedicate more time and commitment to the hospitalized patients. We now have a Society of Hospitalists in Canada and in the US. We have journals and publications specifically about the hospitalized patients. We also have conferences that are dedicated to the care of the hospitalized patients. So it's actually becoming quite a movement now in Canada as well. We've also, in family medicine, it's usually a 2-year residency program now. There's an option of a 3rd year hospitalist teaching program as well that you can apply for after you finish your family medicine residency. So it's becoming more and more recognized. So now that you've heard about it, what is it? What do I do? So usually start the day, and now there's 3 of us. So we divide up the list so we all have an equal share of the patients. So everybody's got the same workload. There will be patients that were admitted overnight, and we'll divide them so everybody gets, like I said, we try and make it as equal as possible. We will start off by seeing the patients, assessing them, doing a bedside examination. We'll often pull in the nurse or other part of the multidisciplinary team. After we've seen the patient, we usually will write orders, follow up on blood tests, x-rays, any outstanding investigations, order other things that we think are important to help to diagnose and treat and move this patient along. We have developed what we call bullet rounds, and these are multidisciplinary rounds. Sounds good, but what it means is we have an occupational therapist, a physiotherapist, our charge nurse, the individual nurse, discharge planner, home care, and sometimes we'll have other volunteers like from Matthew's house, and they'll come in and we will talk about every single patient that's on the floor. We'll talk about why they're here, what they need, how we can move them along, do they need other services, starting to plan for home, how are we going to get them home, is home appropriate, do we need to think about other things. So that starts from day one, that we're really thinking about how are we going to treat you, how are we going to move you through the hospital, and how are we going to get you home safe. And then there's the added piece of when you get home, what kind of follow-up do you need, and how can we be instrumental in organizing that. After we do rounds, we'll finish assessing patients. We'll often follow up on CT scans or x-rays that were done earlier on in the day, but my job is to be there. So if I have a sick person that's I see in the morning that's quite unwell, I keep going back and assessing that patient. Are they doing better? What do I need to give them? What did the x-ray show? Are they needing a higher level of care? Are they no longer appropriate for our floor? So sometimes people become critically ill, and we will need to send them to another hospital, usually an ICU or a CCU, that's an intensive care or cardiac care unit. So it's our job to make sure we can get a bed and get that person there safely. Sometimes we'll actually have to go in the ambulance with them to get them there safely. We'll spend a lot of time on the phone. We are small but mighty. We don't have a lot of specialists. We have a general surgeon, a pediatrician, obstetrician, gynecologist. think that's it, I'm not missing anyone. So we don't have a lot of services, and sometimes we'll need to talk to the cardiologist, to talk to the gastroenterologist, to talk to the oncologist to get some management advice or to access care that we can't provide. So we've spent a lot of time in trying to make inroads with other departments and specialists in various hospitals. It takes a lot of time, but we've been able to build on those relationships, and because of that, we've had great improvements. I started here on the floor 3 years ago, and when I first came, I had someone that I had to get a biopsy of the liver. They had a mass in the liver, we didn't know what it was, and we needed a biopsy. Impossible, couldn't do it as an inpatient. Now, because we've made relationships, that we have a process. So if you need a biopsy, if you need a PICC line, if you need other things that we can't do at our hospital, we have a better access of care, so we can get you the care that you need. Used to be people would sit on the floor for 2 weeks to get a PICC line, which is kind of a semi-permanent line to get antibiotics, that kind of thing, and would decondition. They would not be moved very much. They'd be sitting around in our hospital waiting for interventions. Now we're able to access them more quickly, which means that we're hopefully getting you out of hospital, not letting you decondition or get weaker. So we're there all day. We reassess patients as they need. Some people only need 1 visit a day. Some people need multiple visits a day. Part of our new initiative with this 3 hospitalist model is to try and see you faster. So if you come into the emergency room, prior to this, if you were admitted at 10 o'clock in the morning or 11 o'clock in the morning, nobody would see you till the next day. So you might go 20 hours without actually seeing another doctor from the emergency. Now, because we're there all day, we try and see those people right away. And that means if I'm seeing you at 11 in the morning, I'm starting to order the investigations that are necessary. I'm starting to pull in the physiotherapist and parts of the team that are necessary to get you the care that you need. So we're trying to see you faster, trying to get our team to see you faster, and usually that means that we'll be able to move you through the hospital faster as well. Some people like to stay at our hospital, but most people are keen to go home. And the sooner we get to you, and the sooner that we move you, and the sooner we do all these things, the sooner you get to go home. So that's our job. And so our job, we are paid to care for you all day in the hospital. We do call overnight, we do call on the weekends, so there's always a backup. The good thing is we're there for families. If you're not there at 9 o'clock, well, if you come at 2 o'clock, we can talk to you at 2 o'clock. If you can't come in, we can talk to you on the phone. We do family meetings with the discharge planner and other members, but our job is to be available to the patient, to the family, and to the nurses, and help support the nurses as well. So that's generally what I do in a day. There is another part that's creeping up on me more and more. That's the world of meetings. 3 years ago I had no meetings. Now I have meetings all the time. But meetings are good because what we've been able to do is make some quality improvements. And that's a pretty big buzzword these days, quality improvements in inpatient care. And what that means is we're trying to look at ways that we can make it safer and better and more efficient for you when you're a patient. So the first thing that we did was we introduced those bullet rounds that I just touched on. And we do those every day, review every single patient. We've also created what we call standard order sets. When I come see you in the emergency room, I write a bunch of orders. And we've developed these sets that are specific to the diagnosis. So if you came in with a stroke, if you came in with heart failure, we have order sets that are specific to those diagnoses. This means that we're not going to forget things as much. Because sometimes it's hard to remember every little thing. So if we have a standard order set that's kind of an up-to-date standard of care, it means that if you have a stroke, we're not going to forget to do ultrasounds, or we're not going to forget to put it on a monitor, or things like that. So it's very important that we have the same level of care as every other hospital. So we've developed these order sets, we've checked them with other hospitals, and we continue to improve on them. Another thing that we have been doing is some chart reviews. So we go back in time and look at certain diagnoses. Heart failure, congestive heart failure, or CHF, and COPD, which is chronic obstructive pulmonary disease, are two of those diagnoses we see all the time in hospital. These are pretty chronic diseases. People are quite unwell, and they end up in hospital a lot. So we've gone back in time, looked at charts, tried to review to see how can we do better. Are we documenting how much they're taking in and how much is coming out, which is very important for someone with heart failure. Are we educating people on how much salt they should have, what their diet should be like? So all those things. So we're continuing to do them. We've made some improvements, but we haven't stopped. We're not there, and we're never going to be there, because medicine's always changing and we can always do better. So our goal is to be there for you, but it's also to improve upon what we know and to give you the best care we can. So that's pretty much what I do, which has been, it's been a thrill, and it's been so much fun. And I really do have to thank our administration for recognizing that this is important. And they've made a stand and said, you know what? We need dedicated people to take care of you while you're in the hospital, because you deserve it. So I think it's been a great move. It's been very exciting to be a part of, and I think it's just been a fabulous place to work, and I'm honored to be here.